Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 237 of our pharmacotherapy series, which majors in CNS infections. My first question to you reads, LSC, a 5-year-old boy, is brought to the emergency department by his mother, who says her son has a temperature of 39 degrees Celsius, is irritable and lethargic, and has a rash. LSC was in his usual state of good health until last night, when he awoke crying. When she went to investigate, her son began to stiffen up and rock back and forth in his bed. Because he was not arousable, LSC's mother rushed him to the hospital. LSC's medical history is non-contributory except for an allergy to amoxicillin described as a skin rash. LSC, his mother and father, and his 7-year-old brother recently moved to the United States. LSC's vaccination history currently is unknown. LSC and his brother currently attend a community day care center. On physical examination, LSC was in marked distress, with a temperature of 40 degrees Celsius, blood pressure of 90 systolic 60 diastolic, and a respiratory rate of 32 breaths per minute. His weight on admission was 20 kilograms. Neurologic examination showed evidence of nuchal rigidity. He was lethargic and difficult to arouse. Brudzinski and Koenig signs were positive. On head, eyes, ears, nose, and throat examination, LSC demonstrated photophobia. He squinted severely when the examiner shone a light in his eyes, but no evidence was noted of papilledema. A petechial rash was visible on his extremities. The remainder of LSC's examination was essentially normal. Blood drawn for laboratory tests revealed the following results. Sodium levels were 128 milliequivalents per liter, potassium levels were 3.2 milliequivalents per liter. Chloride levels were 100 milliequivalents per liter. Bicarbonate levels were 25 milliequivalents per liter. Blood urea nitrogen was 16 mg per deciliter. Serum creatinine was 0.6 mg per deciliter. Serum glucose levels were 80 mg per deciliter. The WBC count was 18,000 cells per microliter with 95% polymorphonuclear (PMN) cells. The hemoglobin, hematocrit, and platelet count all were within normal limits. So my question to you is, what clinical and laboratory features does LSC display that are suggestive of meningitis? The most common symptoms include the triad of fever, stiff neck, also known as nuchal rigidity, and altered mental status. When all three of these features are present, as is LSC's case, meningitis should be strongly suspected. Other less common signs and symptoms include headache, photophobia, unusual intolerance to light, and focal neurologic deficits, including cranial nerve palsies. A positive Brudzinski sign, that is, reflex flexion of the hips and knees produced on flexion of the neck when lying in the recumbent position, and Koenig's sign, that is, pain on extension of the hamstrings when lying supine with the thighs perpendicular to the trunk, provide physical evidence of meningeal irritation. Brudzinski and Koenig's signs both were positive in LSC. Seizures occur on initial presentation in up to 60% of patients and may be focal or generalized. The presence of seizures or a severely depressed mental status, i.e., obtundation or coma, generally is associated with a poorer prognosis. According to the most recent practice guidelines for the management of bacterial meningitis, a computed tomographic (CT) scan should be obtained before lumbar puncture in patients with specific criteria. These include immunocompromised state, history of CNS disease, new-onset seizure, papilledema, abnormal level of consciousness, and focal neurologic deficit. Although controversial, brain herniation can occur when lumbar puncture is performed in patients with elevated intracranial pressure because of the pressure changes induced within the cranial vault. LSC has many of the clinical features associated with acute bacterial meningitis. Furthermore, the low blood pressure, i.e. hypotension, and increased respiratory rate are characteristic findings in severe, life-threatening types of bacterial infection, e.g., septic shock, or meningitis, and are likely the result of endotoxin release. The signs and symptoms of meningitis in the very young and very old differ from those in older children and adults. In neonates, signs of meningeal irritation may be absent. Fever, irritability, and poor feeding are often the only symptoms manifested. Because LSC is 5 years of age, accurate assessment of his mental status is challenging. Irritability, that is crying, as was manifested by LSC, is an important finding that suggests an altered mental status. In elderly patients, many of the classic signs of meningeal irritation are absent as well, and the disease presentation can be subtler. Therefore, given the grave consequences of a misdiagnosis, clinicians caring for infants and elderly patients must have a particularly high index of suspicion for meningitis. Laboratory evaluation of meningitis should include serum chemistries and a hemogram as well as a detailed examination of the CSF. The peripheral WBC count often is markedly elevated in acute bacterial meningitis, usually with a left shift evident on the differential. This finding, however, is nonspecific and occurs in many acute inflammatory and infectious diseases. LSC has a marked leukocytosis with a predominance of PMN cells on the differential. The abrupt onset of LSC's clinical symptoms is consistent with an acute bacterial process rather than a fungal or viral etiology. Given his age, 5 years, and the community-acquired nature of the infection, the most likely pathogens for his meningitis are Haemophilus influenza, Neisseria meningitidis, and Streptococcus pneumoniae. The presence of maculopapular lesions argues for Neisseria meningitidis as the causative pathogen because this is a common finding in cases of meningococcemia or meningococcal meningitis. To make an accurate clinical and microbiologic diagnosis in LSC, it is necessary to obtain CSF for analysis. Thus, a lumbar puncture is required as soon as possible. The resident in the emergency department performs a lumbar puncture, which yielded the following. The opening pressure is 300 mm of mercury. The normal value should be below 20 mm of mercury. CSF glucose is 20 mg per deciliter. The normal value is 50 to 60% of plasma glucose. Protein is 250 mg per deciliter. The normal value is below 50 mg per deciliter. WBC count is 1,200 cells per microliter, with 90% PMNs, 4% monohistiocytes, and 6% lymphocytes. The CSF red blood cell count was 50 per microliter. A stat-gram stain of CSF revealed numerous WBCs but no organisms. CSF, blood, and urine cultures are pending. Provide an assessment of the CSF results. Careful examination of the CSF is essential to confirm the diagnosis of meningitis. In acute bacterial meningitis, the CSF is often purulent, containing numerous WBCs with a predominance of PMNs, and often is turbid. CSF protein nearly always is elevated, and the CSF glucose concentration is low. In contrast, CSF obtained in viral and fungal cases of meningitis usually is clear and characterized by a much lower WBC count with a mononuclear or lymphocyte predominance. Although the CSF protein concentration often is elevated, it may be normal. A variable effect is observed with CSF glucose. Let's now consider a microbiologic evaluation. Microbiologic evaluation should include examination of CSF by gram stain and culture as well as cultures obtained from other potential sites of infection, e.g., blood, sputum, or urine. The presence of organisms on smear is indicative of a high bacterial inoculum, i.e., inoculum above 105 colony-forming units per milliliter, and is associated with more fulminant disease. The absence of organisms on gram stain by no means rules out infection, but does make selection of empiric therapy more difficult. Although a positive gram stain should prompt a re-evaluation of empiric therapy to ensure appropriate coverage, gram stain results should not by themselves prompt a narrowing of appropriate empiric therapy. LSC has a negative gram stain, which may be the result of previous antibiotic therapy or the early detection of disease. Given the negative CSF gram stain result, LSC must receive antibacterial therapy sufficiently broad to cover all pathogens associated with meningitis in his age group until the results from his CSF culture are available, usually within 24 to 48 hours. The CSF culture nearly always is positive in purulent meningitis, although CSF cultures can be negative in a patient who clearly has meningitis, particularly with antecedent receipt of antibiotic therapy. Finally, results from cultures of other sites, such as the blood, urine, and sputum, when appropriate, can yield useful microbiologic information. The CSF findings in LSC also strongly support the diagnosis of bacterial meningitis. He has a markedly elevated opening CSF pressure, CSF leukocytosis with a predominance of PMNs, an elevated CSF protein concentration, and a depressed CSF glucose value. A few RBCs are present in the CSF, which suggests contamination with peripheral blood caused by the traumatic nature of the lumbar puncture. Precise identification of the offending organism is not possible until CSF culture results are available. I will now briefly talk about treatment principles. Prompt institution of appropriate antimicrobial therapy is essential when treating meningitis. Delay in antibiotic administration is associated with increased morbidity and mortality. When choosing antimicrobial therapy, a number of factors must be considered. First, the antibiotics selected must penetrate adequately into the CSF. In addition, the regimen chosen must have potent activity against known or suspected pathogens and exert a bactericidal effect. We will now briefly look at antimicrobial penetration into the cerebrospinal fluid. The ability of antimicrobials to penetrate into CSF is affected by lipid solubility, degree of ionization, molecular weight, protein binding, and susceptibility to active transport systems operative within the choroid plexus. In general, the penetration of most antibiotics into the CSF is increased when the meninges are inflamed. Antimicrobial penetration into CSF is most commonly reported as a ratio of CSF to serum antimicrobial levels. Metronidazole, sulfamethoxazole, and trimethoprim are small, highly lipophilic compounds and penetrate into the CSF well, achieving adequate concentrations even when meningeal inflammation is absent. Rifampin is lipophilic but is a larger compound with a high degree of protein binding. Thus, it achieves satisfactory CSF penetration and may be combined with vancomycin to treat coagulase-negative staphylococcal infections in the CNS. Because beta-lactams usually are ionized at physiologic pH, they are more polar and do not penetrate into the CSF as well. Beta-lactams penetrate poorly when the meninges are intact, but when the meninges are inflamed, most penicillins and the third and fourth generation cephalosporins achieve CSF concentrations sufficient to treat meningitis, approximately 10% to 30% of simultaneously obtained serum concentrations. First and second generation cephalosporins are not recommended in the treatment of meningitis due to inadequate penetration and/or inferior efficacy. Ceftriaxone achieves sustained, reliable bactericidal activity within the CSF despite its high protein binding and has been used successfully to treat meningitis in both children and adults. An additional factor working against maintenance of therapeutic concentrations of beta-lactams in the CSF is the active transport system of the choroid plexus, which pumps these organic acids out of the CSF. Meropenem achieves CSF levels 10% to 40% of serum levels. At the present time, data are too limited to draw conclusions on the utility of the newer agents ceftaroline, ceftolozane, tazobactam, or doripenem in the treatment of CNS infections. The aminoglycosides have a low therapeutic index, and adequate CSF concentrations are difficult to achieve with IV dosing alone without risking significant toxicity. Thus, when aminoglycoside therapy is initiated for adults with CNS infections, concomitant intrathecal therapy is usually required. Similarly, the polymyxins are large hydrophilic compounds with substantial toxicity, and thus intrathecal administration is preferred. Vancomycin is a large hydrophilic compound with moderate protein binding of about 50% and as such does not diffuse well across the blood-CSF barrier. Therapeutic concentrations in the CSF, up to 30% of serum concentrations, may be attained with systemic vancomycin therapy when the meninges are inflamed. Other studies have found much lower penetration, however, and as such, concomitant intraventricular therapy also may be necessary in selected circumstances. Consensus guidelines recommend aggressive dosing, with troughs of 15 to 20 micrograms per milliliter, when treating meningitis. Fluoroquinolones are moderately lipophilic, have a molecular weight of approximately 300 Daltons, and are not protein-bound to a large extent. As would be expected, they penetrate reasonably well into the CSF on a percentage basis, approximately 40% to 60% or higher. Despite this, clinical data supporting the use of fluoroquinolones for bacterial CNS infections are lacking, although some hypotheses may be made. First, given its potent activity against Streptococcus pneumoniae, moxifloxacin may be an option for pneumococcal infections with limited therapeutic options, such as infections caused by penicillin and ceftriaxone-resistant isolates. Second, CSF concentrations attained are likely inadequate for infection caused by bacteria with higher MICs equal to or above 0.125 to 0.5 micrograms per milliliter, depending on the specific organism and drug. This is especially relevant because concerns regarding CNS toxicity have generally limited the study and practice of non-standard, increased fluoroquinolone dosages for bacterial CNS infections. Finally, given the high rates of gram-negative resistance to fluoroquinolones, these agents should not be considered reliable as empiric therapy options in patients considered at risk for infections caused by such organisms. Taken together, the fluoroquinolones are rarely utilized for the treatment of bacterial CNS infections. Macrolides such as erythromycin and clarithromycin have a relatively high molecular weight and are substrates for a transporter that is abundant at the blood-brain barrier, P-glycoprotein. As such, they do not reach adequate concentrations when meningeal inflammation is lacking, and their lack of bactericidal activity further limits their utility in the treatment of bacterial meningitis. Bacteriostatic activity against Streptococcus pneumoniae also limits the utility of the tetracyclines and tigecycline. Clindamycin penetrates the CSF fully and should not be used in the treatment of meningitis. Linezolid is also generally bacteriostatic, but as it often retains activity against multi-resistant gram-positive pathogens and achieves CSF levels comparable to those in plasma, it may be considered an option for infections caused by gram-positive infections that are resistant or refractory to frontline options. Daptomycin is generally bactericidal and active against multi-resistant gram-positive pathogens, but it is a large, highly protein-bound compound, and thus, CSF penetration is low, that is equal to or less than 10% of plasma levels. Use of higher doses and intrathecal administration are being actively explored, but current utility is limited. A detailed medication and vaccination history reveals that LSC and his brother appropriately received vaccination for HIV when they were 2 months of age. So my questions to you are, what constitutes appropriate empiric therapy for childhood meningitis? Which antibiotic would be appropriate for LSC? What dose and route of administration should be used? Because results from culture and sensitivity testing of CSF will not be available for longer than 24 hours, empiric therapy must be instituted promptly. The regimen should take into consideration the patient's age, any predisposing conditions, results from the CSF gram stain, history of allergy, and the presence of organ dysfunction. LSC is 5 years of age and has a negative CSF gram stain. Therefore, therapy with a third-generation cephalosporin, such as ceftriaxone or cefotaxime, is preferred. Either of these two agents will provide excellent coverage of the most likely pathogens in this age group, that is Streptococcus pneumoniae and Neisseria meningitidis. Of these two pathogens, LSC's rash suggests that Neisseria meningitidis is likely. Haemophilus influenza is not very likely because he was vaccinated against HIV, thus, initiation of ceftriaxone plus vancomycin would be appropriate for LSC at this time. Use of a cephalosporin in this case is appropriate despite the allergic history with amoxicillin. The patient has a history of skin rash. Patients with a documented penicillin allergy carry a 5% to 11% risk of cross-reactivity when cephalosporins are prescribed, depending upon the agent. In this setting, the type of reaction to penicillin is important to consider. Patients with a history of accelerated hypersensitivity reactions, e.g., hives, shortness of breath, or anaphylaxis, to penicillins should not be given cephalosporins in most instances. Conversely, a benign skin rash would not contraindicate use of a cephalosporin. If LSC had experienced an accelerated reaction to penicillin, vancomycin plus aztreonam, or meropenem would be the best alternative choice. Regarding dosing considerations, in general, therapy of meningitis requires the use of high dosages of antimicrobials administered by the IV route. LSC should receive ceftriaxone in a dosage of 100 mg per kilogram per day given in 1 or 2 doses. A ceftriaxone regimen of 1000 mg IV q 12 hours is reasonable for LSC. My next questions to you read, what is the rationale for adjunctive corticosteroid therapy in acute bacterial meningitis, and would it be appropriate for LSC? How should dexamethasone be dosed and monitored for LSC? Corticosteroids, particularly dexamethasone, can reduce cerebral edema and lower intracranial pressure. In addition, corticosteroids reduce the synthesis and release of the pro-inflammatory cytokines TNF-alpha and IL-1 beta from monocytes and astrocytes. These two cytokines play a central role in initiating the cascade of events that lead to neuronal tissue damage and neurologic sequelae. Theoretically, then, inhibition of cytokine synthesis by corticosteroids in meningitis should lead to a decreased risk of hearing loss and other neurologic sequelae. Indeed, a prospective, randomized, double-blind multi-center trial evaluating the use of dexamethasone in adults with acute bacterial meningitis supported this theory. A total of 301 patients were randomized to receive dexamethasone or placebo 15 to 20 minutes before or with the first dose of antibiotic every 6 hours for 4 days. Dexamethasone reduced the risk of unfavorable outcome, defined as a Glasgow Coma Scale score of 1 to 4 at 8 weeks, with a relative risk of 0.59, with a p-value equal to 0.03, and of death, that is relative risk of 0.48, with a p-value equal to 0.04. When the outcomes were analyzed based upon culture results, mortality reduction 14 versus 34%, and all unfavorable outcomes 26 versus 52% were only seen with dexamethasone therapy in patients with meningitis caused by Streptococcus pneumoniae. Outcomes in patients with meningitis caused by organisms other than Streptococcus pneumoniae were independent of whether they received dexamethasone or not. Neither GI bleeding nor other adverse effects were increased in the dexamethasone group. In children, several studies have also evaluated the role of adjunctive dexamethasone therapy in bacterial meningitis. Some prospective placebo-controlled, randomized trials have demonstrated that adjunctive dexamethasone therapy significantly reduces audiologic and neurologic sequelae in children above 2 months of age. Haemophilus influenza, however, was the causative pathogen in most of these meningitis cases, whereas the number of children with streptococcal and meningococcal meningitis in these trials was small. As previously mentioned, the number of HIV cases has decreased dramatically, making the data from these trials difficult to apply to the present day. More recently, of the 166 patients enrolled in a trial comparing dexamethasone to placebo, 35 and 26 cases were caused by Streptococcus pneumoniae and Neisseria meningitidis, respectively, in the treatment arm. Fewer audiologic and neurologic sequelae were observed in the dexamethasone-treated group compared with the placebo group, but the difference did not reach statistical significance. Most recently, a 2013 Cochrane meta-analysis evaluated data from 25 randomized trials that included over 4,000 children and adults. In the overall population, glucocorticoid administration did not significantly reduce mortality. However, glucocorticoids did reduce mortality in the subgroup of patients with meningitis caused by Streptococcus pneumoniae, with an RR of 0.84, with a 95% confidence interval of 0.72 to 0.98. In studies conducted in high-income countries, glucocorticoids reduced severe hearing loss with an RR of 0.51, with a 95% confidence interval of 0.35 to 0.73, any hearing loss with an RR of 0.58, with a 95% confidence interval of 0.45 to 0.73, and short-term neurologic sequelae with an RR of 0.64, with a 95% confidence interval of 0.48 to 0.85. In the subgroup of over 2,000 children, the administration of dexamethasone did not affect mortality but did reduce the incidence of severe hearing loss, particularly in those with Haemophilus influenza meningitis. I would like to remind you that the 2004 IDSA meningitis guidelines recommend that dexamethasone be initiated prior to, or concomitant with the first dose of, antimicrobial therapy in all adult patients with suspected or proven pneumococcal meningitis. Controversy remains over whether dexamethasone should be continued in adults if the causative agent is found not to be pneumococcus because the number of patients in the studies with meningitis caused by other organisms was small. However, the guidelines do recommend discontinuing dexamethasone if the organism is found to be something other than Streptococcus pneumonia. Regarding pediatrics, the American Academy of Pediatrics Committee on Infectious Diseases suggests that dexamethasone therapy may be beneficial in children with HIV meningitis if given before or at the same time as the first dose of antimicrobial therapy. The American Academy of Pediatrics Committee on Infectious Diseases also suggests that the decision to use adjunctive dexamethasone therapy should be individualized but considered for infants and children older than 6 weeks with pneumococcal meningitis. At this time, there can be no firm recommendation as to whether steroids should be continued in children if the pathogen is found not to be Haemophilus influenza or Streptococcus pneumoniae. Thus, LSC should receive dexamethasone therapy, 0.15 mg per kilogram per dose given IV every 6 hours for 2 to 4 days. For LSC, who is 20 kg, this would be 3 mg every 6 hours with the first dexamethasone dose given 15 minutes before initiating ceftriaxone therapy. Potential adverse effects associated with dexamethasone include GI bleeding, mental status changes e.g., euphoria or encephalopathy, increases in blood glucose, and possibly elevations in blood pressure. For LSC, the complete blood count, serum chemistries, and stool GWAG should be monitored daily while he is receiving dexamethasone. He also should be questioned about possible GI upset and assessed for changes in mental status, e.g., confusion, or combativeness. Given the short duration of corticosteroid therapy, dexamethasone can be discontinued abruptly without tapering. I will now briefly comment on the effect of dexamethasone on CNS penetration of antibiotics. Another important issue to consider is whether dexamethasone, a potent anti-inflammatory agent, reduces the ability of antimicrobials to penetrate across the blood-brain barrier into CSF. Because CSF penetration of the penicillins, cephalosporins, and vancomycin is greatest when the meninges are inflamed, a hypothetical concern is that concomitant dexamethasone may reduce CSF concentrations of these agents, resulting in reduced efficacy. Early animal models suggest that vancomycin penetration into the CSF is reduced in dexamethasone-treated animals compared with animals not treated with steroids. In a rabbit meningitis model, the co-administration of dexamethasone and vancomycin resulted in 29% less penetration of vancomycin into the CSF. By increasing the daily dose of vancomycin in these rabbits, however, therapeutic CSF levels were achieved, suggesting that giving larger daily doses of vancomycin circumvents the steroid effect on CNS penetration. Additionally, current human data suggest that CSF penetration of vancomycin or ceftriaxone is not diminished with concomitant administration of dexamethasone. Based on these encouraging findings, it is recommended that dexamethasone be utilized in all patients. 24 hours after admission, LSC's culture results from his blood and CSF samples are available. The CSF culture is growing Neisseria meningitidis, whose penicillin mic is 0.06 mg per liter, and Neisseria meningitidis is also growing in both of the two collected blood cultures. So my question to you is, what modification in LSC's antimicrobial therapy is necessary at this time? Once culture and sensitivity results become available, definitive therapy can be instituted, often with a single agent. As suspected, LSC's CSF culture is positive for Neisseria meningitidis. Cefuroxime, a second-generation cephalosporin, has activity against Neisseria meningitidis. However, it is less effective for meningitis than third-generation cephalosporins and should not be used. The reason for the inferiority of cefuroxime relative to ceftriaxone most likely is related to reduced potency. Because Neisseria meningitidis is susceptible to penicillin and ampicillin currently, penicillin is the drug of choice. However, LSC's questionable history of amoxicillin rash makes the use of ceftriaxone a reasonable choice. The next question reads, what subjective and objective data should be monitored to evaluate the efficacy and toxicity of treatment of patients with meningitis, and what specifically should be monitored in LSC? Clinical signs and symptoms attributable to the disease, such as fever, altered mental status, and stiff neck, should be checked periodically throughout the day and monitored for resolution. LSC's temperature and mental status should be assessed often. Accurate assessment of LSC's mental status can be difficult because of his young age. Thus, his baseline level of mental status should be evaluated, e.g., whether he is awake and alert, or lethargic and difficult to arouse. If awake and alert, LSC should be observed for irritability, because this often is the only sign of altered mentation. Questions can be used to assess his orientation. Does he know where he is? Does he know his name? Can he recognize his mother or other family members? In general, signs of clinical improvement should be evident within 24 to 48 hours for most uncomplicated cases of acute bacterial meningitis, with defervescence of fever achieved in a mean of 3.3 days in one trial of cefotaxime in children. Laboratory tests should be monitored as well. A CBC with differential, serum electrolytes e.g., sodium, potassium chloride and bicarbonate, blood glucose, and renal function tests e.g., BUN, serum creatinine should be performed daily. Abnormal electrolyte results may require more frequent monitoring. Laboratory abnormalities, such as leukocytosis and hyponatremia, may take longer to normalize than clinical symptoms. CSF chemistries usually improve within 48 hours of starting therapy, although CSF WBC and protein may remain elevated for a week or more. With effective therapy, the CSF culture usually is sterile after about 18 to 24 hours of therapy. Delays in CSF sterilization are associated with a higher propensity for neurologic complications. If LSC responds to therapy in a straightforward manner, he need not to have a repeat lumbar puncture. If the response is inadequate, as evidenced by persistent fever or deteriorating mental status, LSC will require a repeat lumbar puncture to re-examine the CSF parameters. In addition to monitoring the therapeutic response, side effects of the antimicrobial regimen also need to be assessed frequently. Meningitis requires high-dose therapy, making the likelihood of adverse effects much greater. Currently, LSC is being treated with ceftriaxone. The adverse effects most often associated with ceftriaxone include hypersensitivity reactions, mild pain and phlebitis at the injection site, and GI complaints. LSC should be observed for the formation of an antibiotic-related skin rash or evidence of an accelerated allergic reaction, e.g., hives, or wheezing. The IV catheter site should be observed daily for redness, tenderness, or pain on palpation of the vein. LSC should be watched closely for loose stools or diarrhea. Although mild diarrhea is a common side effect of most antimicrobials that rarely requires a change in therapy, diarrhea that is severe, persistent, or accompanied by fever, unexplained leukocytosis, or abdominal cramping should prompt testing for Clostridioides difficile colitis. The next question reads, after 5 days of treatment, the nurse caring for LSC notes that his appetite is markedly diminished, and he complains of an upset stomach. LSC was afebrile and alert and oriented, but abdominal examination revealed guarding, with pain localized in the right upper quadrant area. Laboratory data at this time are as follows. WBC count is 6,000 cells per microliter. Hemoglobin is 12.5 grams per deciliter. Hematocrit is 34%. Platelet count is 120,000 per microliter. Sodium levels are 135 milliequivalents per liter. Potassium levels are 3.6 milliequivalents per liter. Chloride levels are 98 milliequivalents per liter. Aspartate aminotransferase (AST) is 35 units per liter. Alanine aminotransferase (ALT) is 33 units per liter. Alkaline phosphatase is 110 megaunits per deciliter. Total bilirubin is 1.2 mg per deciliter. Amylase is 70 units per liter. A stool GWAIC is negative. So my question to you is, what are possible causes of LSC's abdominal discomfort? A number of possible causes exist for LSC's abdominal discomfort. His corticosteroid therapy may have caused acute GI bleeding, however, the dexamethasone was discontinued 3 days ago and LSC's hemoglobin and hematocrit values are in the low normal range. The negative stool GWAIC result also argues strongly against a GI bleed. Acute pancreatitis is unlikely given the normal amylase result. Viral or drug-induced hepatitis is another possibility but also is unlikely given his normal AST, ALT, and bilirubin results. An intra-abdominal infection also is possible, but this is improbable because he is afebrile and has a normal WBC count. Other causes, such as acute cholecystitis or appendicitis, require further diagnostic evaluation. The next question reads, an abdominal ultrasound reveals sludge in the gallbladder. What is the significance of this finding in LSC, and how should this abnormality be managed? The abnormality on LSC's abdominal ultrasound explains his right upper quadrant pain. LSC has what appears to be a condition known as biliary pseudolithiasis, i.e., biliary sludging. Biliary sludging can occur in conditions of gallbladder hypomotility, e.g., recent surgery, burns, total parenteral nutrition, and, in some instances, can be drug-induced. LSC has been receiving ceftriaxone for treatment of his meningitis, and this drug can cause biliary pseudolithiasis. Antibiotic-associated biliary pseudolithiasis is seen almost exclusively with ceftriaxone. The biliary excretion associated with ceftriaxone results in very high concentrations of the drug in gallbladder bile. In selected circumstances, the biliary concentration of ceftriaxone may exceed solubility limits, resulting in formation of a fine, granular precipitate, i.e., sludge, which differs in composition and ultrasound features from true gallstones. The precipitate is composed of a ceftriaxone calcium complex, the formation of which is dose-dependent. Given the high dosages required for meningitis therapy, it is not surprising that this adverse effect has occurred in LSC in the comparative randomized trial between ceftriaxone and cefuroxime cited previously. Evidence of biliary pseudolithiasis on abdominal ultrasonography was observed in 16 of 35, that is 46% patients who received ceftriaxone, and in none of 35 patients receiving cefuroxime. Pseudolithiasis usually appears 3 to 10 days following the start of therapy and, in most instances, it is clinically asymptomatic. Symptoms similar to acute cholecystitis are evident in some individuals and include nausea with or without vomiting and abdominal right upper quadrant pain. Prompt recognition of this adverse effect and discontinuation of ceftriaxone therapy are required to effectively manage biliary pseudolithiasis. Once LSC's ceftriaxone is discontinued, the condition should resolve gradually over a period of weeks to months. The clinical symptoms should disappear within a few days. Cefotaxime can be substituted for ceftriaxone. Cefotaxime is not associated with biliary complications, and the efficacy of these two agents is equivalent. For LSC, the cefotaxime dosage would be 1000 mg IV every 6 hours. The next question reads, what is the recommended duration of antimicrobial therapy for LSC? The optimal duration of therapy for meningitis is difficult to ascertain because few trials have been designed to address this issue. Although general guidelines exist, the duration should be individualized based on the response to therapy, the presence of complicating factors e.g., immunosuppression, and the specific causative pathogen. Patients such as LSC with meningitis caused by Neisseria meningitidis should be treated for 7 days. Complicated cases, such as those with delayed CSF sterilization, require therapy for longer periods, that is up to 2 weeks or more. The next question reads, LSC is ready to be discharged home. How can the potential spread of meningococcal disease be prevented in persons with whom LSC has contact? Despite an excellent response to therapy, LSC still may harbor Neisseria meningitidis in his nasopharynx and could transmit this organism to individuals with whom he has close contact. Therefore, chemoprophylaxis to prevent secondary cases of Neisseria meningitidis is indicated for LSC and his close contacts. In this context, close contacts include the following: a household member including roommates and young adults in dormitories, childcare center contacts, and any person directly exposed to the patient's oral secretions, e.g., through kissing, mouth-to-mouth resuscitation, or endotracheal intubation, in the 7 days before symptom onset and until 24 hours after initiation of appropriate antibiotics. Healthcare personnel and any passenger on a flight who had direct contact with respiratory secretions, or for anyone seated directly next to an index patient on a prolonged flight, e.g., one lasting equal to or longer than 8 hours, should also receive chemoprophylaxis. LSC's 7-year-old brother, the children at the day care center, and close contacts at the hospital who have been caring for LSC are at risk for invasive Neisseria meningitidis disease and should receive chemoprophylaxis. Because the risk of secondary disease is greatest immediately after onset of disease in the index patient, chemoprophylaxis should be instituted as soon as possible and ideally within 24 hours. Administering chemoprophylaxis 14 days or more after identification of the index case is of little value. Regimens to reduce nasopharyngeal carriage of Neisseria meningitidis include rifampin, ciprofloxacin, and ceftriaxone. The most frequently used regimen for children aged equal to or more than 1 month is rifampin, given every 12 hours in a dosage of 10 mg per kilogram per dose for 2 days. For adults, rifampin given every 12 hours in a dosage of 600 mg for 2 days is commonly used. The index patient should also receive prophylaxis if he or she was treated with an agent other than a third-generation cephalosporin as soon as he or she is able to tolerate oral medications and prior to being discharged from the hospital. Because LSC is receiving ceftriaxone, he does not need chemoprophylaxis. LSC's brother, parents, and day care contacts should be treated with appropriate doses of rifampin as soon as he is diagnosed. Because rifampin is not recommended for pregnant women, ceftriaxone would be a viable alternative. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 238.